Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Ahmed Mansour, for your kind introduction. Thank you, Professor Dr. Amel Bishlawi, for inviting me to this sickle cell session today. And I would like to congratulate you on this very fruitful scientific meeting with very important sessions since yesterday. My topic today is about usually موضوع تقيل دمه شويتين بس I'd rather start with it before the other speakers. We will go further into detailed organ dysfunction in sickle cell disease. It is about the new insights into the pathophysiology and the subphenotypes of sickle cell disease. شغال ولا مش شغال؟ The next slide will be my disclosures and the outline of my presentation. As we already know that sickle cell disease is a monogenic disease, yet it is very unique and pleiotropic in its nature, as you already know, because of its heterogeneity in presentation, but also because of the complex pathophysiology, as well as the multiple phenotypic expression of the disease, which results in various complications. And this diversity in the complications does not only vary between one patient and the other, it even varies longitudinally within the same patient along his different age groups. So is sickle cell disease pathophysiology still a real challenge? I believe the answer is yes, because it is a very complex pathophysiology on the cellular level, on the molecular level, and on the biophysical level. But not only that, it is also associated with multi-system organ. Every single organ can be affected. There is a lot that remains to be unclear in the pathophysiology of sickle cell disease. There are a lot of the disease modifiers, primary, secondary, tertiary, genetic and non-genetic modifiers which affect the disease. And lastly, every day we have new concepts and new hypotheses being proposed to the mechanism and the pathophysiology of sickle cell disease, which make it quite challenging. The bad news is that the sickle cell disease still remains to pose a clinical and economic burden among the entire world, and still it is associated with decreased life expectancy. But the good news is that this has prompted a lot of clinical research and clinical trials in the field of sickle cell disease, and has led to better understanding of the disease, and of course has led to the development of novel therapeutics. And if you look to the clinicaltrials.gov and you search only for interventional studies on sickle cell disease, you will find more than 600 ongoing clinical trials of various etiologies. And over the last 6 or 7 years, we have witnessed a vast improvement and development in the novel therapeutics of sickle cell. Some of them have been approved. 4 agents have been FDA approved after 30 years having only hydroxyurea as the only standard of care for management of sickle cell disease, and a lot are to come more in the pipeline, as will be explained later on by Dr. Miguel Abou. So what is the story of the pathophysiology? This slide, I guess everyone in hematology has come across this slide, which goes back to so many years ago. And this is the old story and how we understood sickle cell disease at that time. And unfortunately, it's not that simple. It's not only 2 phenotypic presentations, either the hemolytic or the vaso-occlusive, and each one of these leads to a number of complications or organ affection. The disease is much more complex than that. And now, based on all the current evidence and all the studies over the last 5 years, it is believed that the sickle cell pathophysiology is driven by a vicious cycle of 4 main processes that I will be covering in the next, hopefully, 15 minutes. So, what are these 4 main processes? I would like to apologize that no pointer will be acting on this. First is the hemoglobin S polymerization, which is still the fundamental and the main event that underlies and drives the sickle cell pathophysiology. This results in what we call the vaso-occlusion, which is mediated by the impaired rheology of the red blood cells and with the increased adhesive properties of the sickle erythrocytes, the platelets, the neutrophils, and the endothelium, and it results in what we call ischemic reperfusion injury, which activates inflammation. On the other hand of the cycle, the hemoglobin S polymerization results in hemolysis, which mediates endothelial dysfunction, which is one of the hallmarks of the disease. And this is mediated by 2 main events, the nitric oxide depletion and the oxidative burst, or what we call the ROS, or reactive oxygen species generation. And of course the production of heme, which is a very important molecule, as previously explained yesterday by Dr. Ryan. It is a very harmful molecule which initiates, and I will explain later how, what we call sterile inflammation. Sterile inflammation is an activation of inflammasome in the vascular and the cellular cells, resulting in cytokine storms. A lot of pro-inflammatory and pro-thrombotic stimuli or cytokines, which exerts a positive feedback loop again, which will result in, again, vaso-occlusion and hence a vicious cycle. My scope of presentation will not include the hypercoagulability and the thromboembolic pathophysiology in sickle cell disease, because I know that this will be covered thoroughly by Dr. Siham later in this session. So what about the first process, the hemoglobin S polymerization? As you already know, that upon the oxygenation of the hemoglobin S, it forms polymers which distorts the red cell membrane, and thus it results in a cascade of events: sickling, cellular dehydration, further aggravated by what we call the Gardner's channel dehydration, cellular energetic failure, impaired rheology, and premature hemolysis of the red blood cell. But this polymerization is not constant. It's always affected by a number of factors. This include intraerythrocytic hemoglobin S, directly proportional to the polymerization, inversely proportional to the fetal hemoglobin level, and a lot of genetic and non-genetic factors as well. Not only that, there is increased adhesive properties of all these cells, whether the erythrocytes, the endothelium, the platelets, or the neutrophils in sickle cell disease, abnormal movement and rolling of cells with impaired blood flow due to the increased plasma viscosity and the impaired red cell rheology, and in the end, endothelial dysfunction again. And this endothelial dysfunction is further aggravated by the nitric oxide depletion, as you already know, is a very important vasodilator, smooth muscle relaxant, important for maintaining the function of the platelets in an inactive state, as well as the function of the endothelium, and this results in what we call the vaso-occlusion vasculopathy. Very important, this slide, which I find it, Anna, as a clinician, very important to me personally, is that these vaso-occlusive events initiate a cascade of downstream events through 5 main pathways, resulting in a positive feedback loop again, and another vaso-occlusive, and this is what we call secondary vaso-occlusive events. And this, of course, highlights something, that this prolongs the duration of the vaso-occlusive crisis and prolongs the hospital stay due to vaso-occlusive crisis. And this calls for very early management. Please do not wait for your patient 2 to 3 days tolerating the pain. The earlier the intervention, the better the control of pain early, the better the offset of this vicious circle. And one of the two mechanisms that I want to highlight here, which I find quite interesting, is that with the vaso-occlusion and the enterocyte damage, there is increased intestinal permeability and increased translocation of the luminal bacteria and the bacterial products, resulting in activation of the neutrophils and what we call circulating aging neutrophils, which result in another inflammatory cytokine storm as well. Not only that, but also the stress which is associated with pain releases two important mediators: the epinephrine, which results in further mediation of adhesive properties, and glucocorticoids, which further enhances this bacterial translocation. So again, we have a vicious circle with the vaso-occlusive crises calling for early management. Without going into very long details of adhesive molecules, endothelial dysfunction and inflammation increase or upregulate the expression of adhesive molecules. Specifically, the selectins, which are expressed by the endothelium, the P and the E selectins, which are now very important targets in the management of sickle cell, as well as the ICAM and the VCAM and leukocyte chemoattractants, and also activates the cells, the neutrophils, the platelets, and the monocytes as well. So this is the main process. What is the second process? Is the intravascular hemolysis. Is it a key player in sickle cell? The answer is definitely yes. We have now a lot of evidence showing that patients with sickle cell disease who have a lower hemoglobin steady state and have higher intensity of hemolytic anemia are more prone to vasculopathic complications, primarily the highlighted ones: the leg ulcers, priapism, pulmonary hypertension, systemic hypertension, nephropathy, gallbladder disease, and even associated with increased mortality. So certain subphenotypes of sickle cell disease relate more to the severity of hemolytic anemia. And this calls again for the management that you have to maintain your patient on an acceptable level of hemoglobin, either by the hydroxyurea as a disease-modifying agent or even by transfusion. So how intravascular hemolysis acts? a very complex pathway, معلش استحملوني in this slide, through the production of the free hemoglobin with hemolysis. It undergoes oxidation, وده ممكن بالنمبر, as well as the release of L-arginase which consumes the L-arginine وبالتالي بيعمل nitric oxide depletion. The free hemoglobin through oxidation reaction results in two things: production of hydroxyl radicals and ROS, and at the same time depletion of the nitric oxide. But most important, it results in the production of the free heme, the bad guy here. The free heme can do two main events. First, it stimulates the production of the placental growth factor as well the endothelin-1, creating a state of chronic inflammation, platelet activation, endothelial dysfunction. But most importantly is the product. ما بيشتغلش البوينتر، عشان كده حاطه ارقام احتياطي. وما قالوا مش هيشتغل على الشاشه. لا ما بيشتغل. لا احمر. اشتغل، انا معايا واحد بس هم قالوا لي مش هيشتغل. ميرسي يا دكتور امال. The second، شايفينه؟ طيب. The second thing is the activation of what we call toll-like receptor 4 ligands or increase, resulting in activation of sterile inflammation by generation of three things: the ROS, and very importantly something called the NETs or the neutrophil extracellular traps, which are generated or released from the activated neutrophils. And the last is the toll-like receptors. ضعيف بس قوي. And this initiates what we call ضعيف قوي مش فاهم. ثانية واحدة أنا معايا بتاعي. مش هيبان. And this initiates what we call the inflammasome response and release of inflammatory mediators, أهمهم الانترلeukin 1 beta and interleukin 6, which have now drugs in the pipeline to counteract their effects. And this of course results in the activation of platelets and the neutrophils and the endothelium, increased expression of adhesion molecules, and all of this results in alteration with the endothelium, ending in the vaso-occlusive crisis. Not only that, but it also releases ATP and ADP, which cause further platelet aggravation. The third process is the inflammatory stimuli, or what we call the sterile inflammation. Sickle cell disease is a model of constant ongoing inflammation stimulated by various endogenous and exogenous stimuli. But under normal adaptive mechanism, the patient has normal adaptive or compensatory mechanism which compensates for this ongoing inflammation. But when it is overcome by certain infections, inflammations, hypoxia, deoxygenation, what happens in that these adaptive mechanisms are overruled or overcome, resulting in vaso-occlusive crisis, ischemic reperfusion injury, and again the vicious circle between inflammation and vaso-occlusion. Without going into these details, الحقيقة very complex slide, I just want to highlight the vicious circle of hemolysis, ROS, nitric oxide production, sterile inflammation, inflammatory cytokines. But I want to highlight the role of few points which are fields of interest now. Is the complement, because there is evidence that the heme can activate the complement pathway with its potential consequences on the endothelium. Also, the exposure of phosphatidylserine on the surface of the red blood cell binds the complement, resulting in premature cell death. Also, the microparticles, and we have a publication with Dr. Ilham Yusri about the microparticles in sickle cell disease and how this can predispose to further chronic inflammation, vasculopathy, and hypercoagulability. And lastly, other mediators at the endothelin-1, which results in further burst of the reactive oxygen species and also results in further Gardner's channel dehydration, resulting in further impairment of the red blood cell rheology. آخر complicated slide, which is the role of the immune system. The immune system, or the innate immune system in sickle cell disease, is primed and activated, promoting adhesion, inflammation, and chronic pain. An entire orchestra of cells are acting all together, resulting in inflammation, adhesion, and pain. Starting by the monocytes, which when activated release inflammatory cytokines and result in inflammation and adhesion of these activated cells to the endothelium. They undergo transendothelial migration when the sickle erythrocytes interact with the endothelium. When they roll on the sickle endothelium, they take up the cellular debris or scavenge the cellular debris and result in what we call upregulation of the heme oxygenase 1, which was very beautifully explained by Dr. Ryan yesterday, and its role. Macrophages as well initiate a vicious circle of chronic inflammation and release mediators as the tumor necrosis factor alpha and the interleukin. The neutrophils, of course, when activated, they bind through the P-selectin to the endothelial cells. They release the nets that I have just mentioned on the neutrophil extracellular trap, which is a very important prothrombotic and pro-inflammatory effect. Also, it interacts with the sickle erythrocytes and captures the sickle erythrocytes when the endothelin E-selectin is upregulated through what we call the MAC1, and this is one of the effects of the IVIG, by the way. And then lastly, it can also interact with the activated platelets expressing the P-selectin. So this is for the neutrophils. What about platelets? When they activated, they release thrombospondin, CD40 ligands, which can bind to the CD36 on the endothelial cells. This one is the mast cells, which is a very important, is also a therapeutic target now. The mast cells releases histamine, causing plasma extravasation, releases substance P, causing neurogenic inflammation and pain, and a vicious circle of release of substance P in sickle cell disease. It also mediates the immune cell recruitment through the cytokine and chemokine storm induced. We also have what we call the invariant natural killer cells, which release tumor necrosis factor. And lastly, even the eosinophils, when they are activated, they result in further potentiation of the oxidative stress and the release of ROS. And all of these mechanisms are targets for therapeutic molecules which are being investigated nowadays, and I know that this will be thoroughly covered later on. So this brings me to the second part. What are the disease modifiers and the disease phenotypes? We know now that the main complications of the disease fall into two main categories, either called by the large vessel vasculopathy or by ischemic organ damage. But these are modified by a number of factors. The genetic modifiers, of course, you know the genetic haplotypes of sickle cell disease, with the African forms being the most severe, the Bantu, the Benin, the Senegal types, with the less severe form as the Arab Indian, which is associated with less severe phenotype. The co-inheritance of hemoglobin F or persistence of hemoglobin F, as well as alpha thalassemia, I will cover in the next slide. And of course, most importantly are the non-genetic modifiers which call for modification of the lifestyle of the patient, including exposure to the cold weather, wind, humidity, poverty, pollution, infections. All of these affects the hospitalization rate. We have evidence now that the co-inheritance of alpha thalassemia is protective against some of the disease, some phenotypes, especially the stroke, priapism, leg ulcers, nephropathy, and as well as the hemoglobin survival and the hemoglobin level and the survival, and the high fetal hemoglobin, especially if above 30, which is one of the also lines of treatment in sickle cell, is protective against the VOCs, against the acute chest syndrome, and as well as again against the leg ulcers. This is one of the introduced hypotheses that I find interesting وحبيت أقولها لكم. And there is one hypothesis about the role of the gut bacteria and the role of microbiota in enhancing gamma globin expression and increasing the fetal hemoglobin level. You know that the gut microbacteria acts on certain dietary fibers, producing what we call probiotics, and these probiotics, through different signaling pathways, whether direct or indirect, act as what we call as an epigenetic regulator, enhancing the expression of gamma globin and increasing the hemoglobin F. And this is one of the points of interest that I really found. Lastly, the SNP analysis have allowed the detection of different genetic polymorphisms which are associated with different disease genotypes. Of course, I cannot go through this, but زي ما انتم شايفين كده, it's all about genetics again. And this brings me to the last part of my presentation, which is only 3 slides, which is I'm going to reflect of what we have said about one of the disease complications or subphenotypes, which is the CNS disease. As you already know, that all of what we have said converge into 2 main vasculopathies, either large vessel vasculopathy or small vessel vasculopathy. And from the standpoint of the organ perfusion, we have a paradox where the hypoperfusion at the level of the microcirculation exists due to the microvascular occlusion and the altered vasoregulation on one hand, and on the other hand we have hyperperfusion of the macrocirculation. And these both paradox in perfusion coexist. And this paradox is called the perfusion paradox, which has profound effects and deleterious effects on both the cardiopulmonary system and may contribute to pulmonary hypertension, as well as to the cerebrovascular system. So what we have in sickle cell disease, we know that the risk of stroke in children is more than 10%, especially if the patients are not screened with PCD. And this is a typical example of both the large and the small vessel vasculopathy. Stroke is primarily caused by involvement of the large and medium-sized arteries of the internal carotid artery and the middle cerebral artery, and it is primarily driven by what we call the decreased cerebrovascular reserve. Decreased cerebrovascular reserve, as well as decreased autoregulation. Cerebrovascular reserve in pediatrics is already maximized under the steady state. So whenever there is additional factors, there is no reserve to compensate for these additional factors, and not to mention hemostatic activation. What about the cognitive impairment? This is related to small vessel vasculopathy, lacunar infarcts, silent infarcts, and in some studies even cognitive impairment is even present without the evidence of silent infarcts, and this may be due to dysfunction. A model الحقيقة one of the hypotheses بتقول ان the increased shear stress associated with the endothelial dysfunction result in what we call endothelial injury and intimal hyperplasia, at the same time further aggravated by the endothelial dysfunction نتيجة الhemolysis, nitric oxide depletion, adhesiveness, and all of this further augmented by the platelet activation and the hemostatic activation result in stroke or the thrombosis through three main processes: cellular activation followed by thrombus formation and reperfusion injury, further aggravating the problem. My conclusion, sickle cell disease remains to be a very complex disease, still a lot to be further understood in the pathophysiology of sickle cell disease, which results in different disease subphenotypes. The large and small vessel vasculopathy together with the perfusion paradox accounts for a lot of complications of sickle cell disease. And lastly, a lot of research has led to better understanding, and this has led to the development of a lot of novel therapeutics over the last 4 or 5 years. And with this, I would like to thank you very much and thank you for your time.